As I said, Ann and I often disagree on things, but I just love her energy, and so I think you should take that as a positive, that we will solve problems. And if I may embarrass my colleague, Dr. Sheffield, I'll start with a perennial doctor joke. I've got good news and bad news. Okay, so first the bad news. And by the way, I want to talk about Medicaid from an orbital standpoint, not from the weeds or the trees or even the forest, but the whole program. The bad news is that it is failing. It is failing despite the Herculean efforts that the Commission is doing. It is failing, for example, less than half of Texas doctors accept Medicaid. Wait times are going up to see a general doctor. I actually urge the committee to take the time and look at the public testimony in the last session on July 25th from a whole series of people who were receiving Medicaid benefits, couldn't get oxygen on the weekends, had to cut their medications in half because they couldn't get refills, et cetera, et cetera. We are not doing what needs be done for the welfare, the health and welfare of our people. So,
just real quick, is that you say Medicaid is failing? Is Medicaid failing, or is managed care failing?
Oh no, this has been ongoing. And I will answer that also, since you're interested in money, on the fiscal side. This is long before managed care was failing. I mean, if you just look at the numbers, and you guys probably know it better than I mean, in 2000, we were spending 10.0 billion taxpayer dollars. We're estimated to spend a year. We're estimated to spend 31.9. That's a 300% increase. Percent of, and here's actually a very important point, percent of Texas budget in 2000 was 20%, and now is 29.8% of your spending. And here we get to, if you will, the good news. The good news is that we can fix this, but you have to fix it by starting having Texas control Texas Medicaid rather than Washington control Texas Medicaid. And that's why I said we have to talk from the orbital standpoint first before we talk about the details of DSRIP and so forth. Now, let me read something to you. There it is. I'm going to give you this written in a second.
Oh, also, I'm sorry. The statistics you just gave about
yes?
what was the first the year that we spent?
2000, we spent 10.0 billion, and 2018 we are slated to spend 31.9 billion.
And what do you contribute that to?
Well,
I mean, is it caseload growth? Is it
yeah,
cost
I mean, again, 1.9 million Texans were in Medicaid in 2000, and now we are estimating 4.5. So that's more than double the number of caseload, and I have to add the cost of bureaucracy, specifically federal.
But we haven't changed eligibility.
Exactly.
Requirements, right?
Yes, we haven't changed, but they have.
But we have an influx of newly eligible people, and I say newly from 2000 to 2018.
Yes, and you're quite right. Yes, we have a huge population growth. A lot of it is going into Medicaid. That's caseload is the number one driver of cost, and everybody knows this.
Caseload, not cost growth?
Well, caseload drives cost.
Yeah.
I mean, there are other things that are cost drivers, but that's clearly number one. The more people you put into the program, which is one of the problems, by the way, and I don't want to get off track, but one of the problems with per capita is the perverse incentive to simply sign up more people. And if you sign up more people, more heads, you get more money. And maybe we won't sign up inappropriate people, but I would worry that some states would. I'll just leave it at that. Let me read something to you which you probably don't know, but you need to. Section 1801 of the Medicaid law, quote, prohibition against federal interference. And now the rest of that section. Nothing in this title shall be construed to authorize any federal officer or employee to exercise any supervision or control over the manner in which medical services are provided, given, or the administration or operation of any such institution, agency, or person. What that says in my language, and I'm not a lawyer, is Texas is supposed to control Texas Medicaid. Texas is supposed to administer Texas Medicaid. And my point is the root problem that we have is that we can't. We have to follow federal mandates. And so we were talking earlier about waivers, and the waiver that has been apparently fairly successful, the movement into managed care. Every criterion that I've seen so far would suggest that it is successful. My point is we are now controlling that part of the Medicaid program, and that's a good thing. And what I'm going to advocate in just a second is that we do just that. We control, Texas, you, the legislature, the HHSC, controls Medicaid rather than Washington control it. Now, there are two ways to do that. One is to opt out of the Medicaid program, and then we can control it. There's a minor little problem of the loss of $17 or so billion a year, so maybe I'm not going to advocate that option, but I will tell you that we at TPPF are looking at financial models about whether that's not quite as crazy as it sounds. I'll just leave it at that and say we're looking at it. I make no promises. Okay?
Yes, well, because we would love to hear where you think you're going to get that $17 billion in GR.
I didn't. I say nothing other than.
I assume that it would not be. You would not be advocating any kind of a tax or fee increase.
I'm sorry. This is TPPF speaking. Are we going to advocate a tax increase? I don't think so. Now, there are three kinds of waivers, and you probably know this, so I'll run through it fast. There are three kinds of Medicaid waivers. One is 1332, which is part of the Affordable Care Act. The big problem with that is that it says things like provide coverage at least as comprehensive as, at least as affordable as, and at least a comparable number to those already eligible for Obamacare, which quite frankly is expansion. So Texas, would have a huge problem trying to work within those guide rails to then get control of our own program. So I'm respectfully, unless SEMA, Verma, and Congress change that, I don't think that that's very useful. The second is the 1915 waiver, which you may know about, which we have and we have used, and that's for home and community health care. Another good thing, but that's all. There's no preventative, there's no acute care, there's no hospitalization, there's no institutional care, so that's a tiny piece of the puzzle. The big one, of course, is 1115 waiver, and I'll just read that one to you. In the case of any experimental pilot or demonstration project, which in the judgment of the Secretary, and that's a key phrase today, is likely to assist in the promotions of objectives of Title I, the Secretary can waive compliance, period. So what I'm trying to say is we should be moving forward and leading on a waiver. You know, people are talking work requirements, and I'm going to talk about that in 1 second. But the bigger issue is we need to, and if I may somewhat disagree with my colleagues in the Commission, we don't need to monitor. We need to lead in the effort to get Texas control of Texas Medicaid. Sir, I'm sorry.
Hey,
sir.
Yes. What does that mean?
It means that
it's one of those terms of like, well, we need to lead. Like that. Go ahead.
What it means is we should create a new waiver, waiver request, ask for things like there are all sorts of cost sharing, work requirements, and I'm going to give you a list in a second. The point is we can't do those things as long as we obey all the federal mandates under Medicaid, which are not just Obamacare. There have been thousands of federal mandates for every omnibus budget reconciliation bill. My point is, I would like to have us say, yeah, that's a good mandate, and we're going to live by that one. That one restricts. Dr. Sheffield and I have talked already about in the past about elder care. I mean, there are a number of federal mandates that prevent us from doing things that would get people out of institutions and into home health and into assisted living. My point is, those are things that we should make the determination for our people rather than having Washington mandates dictate what we do and how we spend the money. Is that an answer, sir?
So essentially, your proposal is we do the things that Washington tells us that we like, and don't do the things that they tell us we don't like.
And ask to waive those mandates and say, we have a better way. This is the way we propose to demonstrate that it works.
Any other laws that we should or just decide we're not going to follow?
Well, it's not. I mean, we're following the law. The law is the waiver. So, I mean, I'm not going to go beyond Medicaid because that's my charge today. You probably know this also, but, you know, Texas took the first step. When you were talking about, or when they were talking about the 2011 1115 waiver, which was passed in 2011, the legislature passed two 1115 waivers. One was the one that was passed, went to Washington, got approved, and just got renewed. That was for managed care. The second went to Texas law. It's Chapter 537 of the Texas Government Code, and it is a block grant request and essentially a global waiver of federal mandates for 5 years in Medicaid. Chair Nelson, at the time the chair of the Legislative Oversight Committee, looked at the, shall we say, political climate and said, they're going to probably laugh at us if we say we want to get out from under Washington under that administration, under Obamacare. Under that administration, we don't know the effects of Obamacare. This is 2011, 2012. So they just left it and was not advanced. And one of the things I'm going to say in a second is I think we should move forward with Chapter 537. So the legislature's already passed that. Political climate, I don't think I need to tell you that things are radically different in 2018 than they were in 2011 and 2012. I would just remind you of the first of the President's executive orders. Quote, to the maximum extent permitted by law, the Secretary of Health and Human Services and the heads of executive departments and agencies shall exercise all authority and discretion available to them to waive, defer, and grant exemptions from or delay the implementation of any provision or requirement of the Act, meaning the Affordable Care Act, that would impose a fiscal burden on any state or state cost. Again, as you know, we in Texas are having a huge crowd-out effect, with 30% of the state budget now mandated to be spent how they choose to spend it, namely how Washington, not how you choose to spend it. There's a big crowd-out effect on education, on infrastructure, on police security, et cetera, because you don't control the first third, almost, of the money that you're allocating. So that's a major problem. Secondly, I think someone referred to it earlier, but here it is directly, and it's in the stuff I'm going to give you. SEMA's first memo was, quote, opportunities to promote work requirements and community engagements among Medicaid enrollees. My point is that this is a very different environment, political environment. What I'm saying is they're more interested and more likely to listen if we say, hey, we want to waive this, we have a better idea, this is our better idea. That's more likely to receive a positive response, I believe, in Washington, and why I think this window of opportunity is wide open at the moment, but is likely to change. Now, if we got freedom, let's discuss what the heck we would do with it. Well, you know, there's a long list that I put on here, and I'll hand you the written stuff in just a second. But things like a global waiver, a fixed sum block grant, use of what I call the Brenner effect. Joel Brenner showed that if you spend a little money now to make people healthier, you end up saving a huge amount of money in terms of avoided costs. Nobody ever talks about that way. Nobody talks about dollar efficiency, which is what we should be doing rather than cost savings. Work requirements, we're going to have a paper for you shortly, the title of which is Medicaid Work Requirements, Code for Personal Responsibility. Now, nobody in his right mind would want somebody who's disabled and in a power chair to then be forced to work, although I forget his name, the advocate who's here all the time. Yeah, I mean, he works harder than I do. I mean, anyway, my point is nobody's going to say that, but we are saying that there has to be a change in the character from a pure entitlement, we think, to one of personal responsibility and an exchange. In return for getting something, you give something, whether it's volunteering in the community, whether it's caregiving, whether it's reading stories to the elderly, whatever it is, there should be some exchange, and that's why we say work requirements are a lot more than work requirements. And again, in the stuff that I will hand you is a chart showing what is listed under work requirements in the various waivers that have already been submitted, 3 of which, of course, have been approved. Cost sharing, even if it's a small amount, changes the dynamic enormously, and so we would recommend consideration of that. Volunteerism, caregiving, time limits on support, 7, I think, of the waivers that have been submitted to Washington, 3 of which have already been approved, have time limits on support. How much, how long, that's your decision, not mine.
Does your analysis take into consideration what the Texas Medicaid population is?
Of course.
Pregnant women, children,
Yes.
and the disabled.
Yes.
The majority of of the Medicaid population are children, so
they're cheap, but yes, the problem in terms of money is the elderly.
That's an expensive population, yes.
24% or so of the Medicaid budget goes to the elder care.
And so your analysis takes into account what the Texas Medicaid population is, not what other states' Medicaid population.
Yes.
I think sometimes you could be assuming an expansion population.
No. I'm fully aware and intensely aware of how dependent versus the potential for independence, how dependent so many of our Medicaid population is in contrast to a number of other states. Yeah, I'm acutely aware of that. And as I said, the big problem for me is the elder population, okay? But there are ways that we could change the financing. I'm not trying to kick, an Alzheimer's patient out on the street. What I'm saying is there are ways to restructure the financing to encourage home care and so forth and give them better services rather than simply doing what Washington tells us to do. That's all. And finally, simplification. Under the current system, where Washington controls literally how the font of the application forms, if we had control, we could simplify things dramatically. That would cut our cost enormously if we could do a radical reduction of the administrative cost, which, by the way, nationally, I don't know Texas, I can't get the data, I've been trying. Nationally, 40% of all healthcare spending doesn't produce any care. It goes to bureaucracy, administration, rules, regulation, compliance.
That's interesting. Why can't you get the data on Texas?
It's very hard to sort out. It's very easy to get expenditure data. I mean, HHSC's got a ton of it. But how do you tease out the actual payments to hospitals, doctors, wheelchair manufacturers?
The MCOs aren't willing to give you that information?
I'll try and say this calmly. No. It is considered proprietary. I've tried. It is considered proprietary information under these contracts, and it's like, forgive me, I shouldn't be this flip, but it's none of your business.
But it is our taxpayer.
But it sure as
our
heck
tax
is
dollars.
your business. Yes, I would love to have a good, not estimate, a good determination of how many dollar efficiency. We keep talking, and I'll get off that soapbox, but I've got to get on it for a second. We keep talking about cost savings, cost reduction, when we should be talking about dollar efficiency. And we should start every conversation, in my view, with dollar efficient. How many of those dollars that you put into that program, whatever the program is, actually end up providing care to a human being? And what's the slippage between A and B? And I think if you actually had accurate data, you would be astonished and depressed, I'm sorry, at how much slippage there is. Anyway, so that's my list. I'm a big fan of restructuring the financing of long-term care because I think there's a lot of cost savings in there. Our estimate on a different matter, just for strict verification, if we had control of verification in our state, which we do not, because we have to follow federal guidelines, our minimum estimate is a savings of $1 billion. Just from that alone. So let me end with my sort of call to action. Number one, we, that is you, should encourage the governor to, forgive me, send a letter with one sentence in it to HHSC saying, move forward with Chapter 537. And in turn, HHSC should say, okay, what could we do to improve the care for Texans and save money at the same time? I don't think that that's a crazy idea, quite the contrary. If we had freedom from that mandate or this mandate or the financing structure of long-term care, et cetera, there are lots of verification. There are lots of things that we could do if we could get control of our own program, and that's what my call to action and my urge is to this committee and the legislature.
And thank you. I appreciate your testimony, and it kind of circles back to the very beginning when we were hearing from the agency.
Yes?
And I said, you know, what policies are they advocating for? And they said, we're here just to monitor. So, and then you are advocating, you know, for some specific actions, and who would be doing that? Who would that be the agency?
Okay, assuming we did these things that I want to do, the governor would say, hey, move forward, HHSE. HHSE would consider all these various things and decide, okay, we want a waiver of that federal requirement, and we're putting that into a Section 1115 waiver, which is already law in Texas, so all you got to do is fill in the blanks. We want that waived, we want that waived, we don't, this is fine, leave it alone, we want that waived, and this is what we're going to do with it, because CMS is going to say, okay, you want to waive that elder care requirement for whatever, what are you going to do in place of that? Right. So they have to be able, HHSC, has to be able to say, okay, well.
HHSC, the executive agency.
Well, in this case, Medicaid division of HHSC, but yes, that would have to come from them. That leadership would have to come from them.
Thank you.
Sir, how are you?
All right.
Thank you very much.
Thank you.